9월 23일 EGM 컨퍼런스 시작되었습니다. 다음 자기소개하고서 시작할게요.
Good morning, Professor, and good morning, all the fellows. Today, I would like to present one EGM case. So this is a 43 years old male with chest complaints of palpitations and recurrent palpitation for the last 3 years. No past medical history, and TEE is normal with normal feeling patterns. This is his ECG taken during the hospitalizations. We can see the data well, which is positive and negative in deep V1 and very deep as well in V1, and also positive in AVF indicated that the patient have possible septal bypass tract and also a very high septal, possibly at the anterior septal bypass tract. This is the ECG recording during Holter. We can see also the same broad QRS with delta wave and also tachycardia. Chest X-ray is normal, and we start our EP study. This is catheter, initial catheter positions. We put a duodeca in the low atrium and CS with his catheter and OV apical catheter. Initial is sinus rhythm with we can see a negative AH interval, HV, sorry, we can see a negative HV interval with data wave. We start overdrive pacing, and we found that AV block cycle length is 320 milliseconds with the change in the activation sequence from subtal to the lateral. So at 260, the accessory pathway block cycle length was noted. Single study, we found that there is no decremental property of the VA conductions at 40, 640, 180 milliseconds and 320 milliseconds. There is no decremental property of the VA conductions. With 600 and 320 milliseconds, subtle accessory pathway ERP is reached, and also for the left lateral is 240 milliseconds. We can see at this one, the retrograde A is noted at HS12, and then it changed to an earliest at CS12. A overdrive pacing, bypass tract block cycle length is at 320. That is less than a AV block cycle length. There is no short narrowing of the QRS. Single study, bypass tract ERP is at 600 and 320. You can see the block here without QRS. So we start isoprotenolol 3 microgram because we cannot induce tachycardia. At the ball A extra 450, 350, and 270, we can induce a tachycardia with a VA interval of 95 milliseconds, tachycardia cycle length of 275 with earliest retrograde atrial at HS12. This is the ECG during tachycardia. After PVC on his, the sequence of retrograde A activation changed from earliest at H12 to the earliest at CS12. So,
Go back to it. Okay, let's discuss with this EGM.
yes.
Can you explain the mechanism of the sequence change by V extra?
Actually, I have one slide at the end of the presentation that explain this one.
Okay,
So I explain or
explain now.
explain now? Okay. This is the possible explanations of this EGM. So the first one, with tachycardia inductions, we can see that the earlier signal is at HIS1-2. The possible reason is that the retrograde is through the enteroseptal bypass tract, and after PVC on HIS, we induce a PVC. There is a fusion bit that go up to the enteroseptal bypass tract and left lateral bypass tract at the same time. And then, okay, and then enterograde to the AV node. Conduction is a little bit slow because it's earlier. And then, because it's early, it blocked in the enteroseptum as we saw at the first EGM. The retrograde AOP of the enteroseptum is longer than the left lateral. So because of the early PVC, it blocked in the left lateral, and then it conduct through the left lateral, it blocked in the enteroseptum and conduct through the left lateral. That's why we can see the sequence change here.
Okay. Does everybody agree to Dr. Hang's explanation? Okay, let's go ahead.
This is Diana, the SVT with earliest retrograde A at CS12, which is different from the previous tachycardia sequence. Also, ECG is the same. So the final conclusion after EP study, we can conclude that the patient has a manifest bypass tract on 12-lead ECG as we saw the data well. There is no VA decremental property, so we can exclude the AVNRT as the mechanism of tachycardia. First, earliest retrograde atrial activity is at HIS1-2, with also no decremental property indicated a septal bypass tract. PVC on HIS change the sequence of the earliest A to CS12. So left lateral bypass tract is also present in this case. So we can conclude that the patient has a multiple bypass tract, including a septal, enteroseptal, portable, and left lateral bypass tract together.
Okay.
Okay, before you do catheter ablation, Hang,
Yes, Professor.
Go back.
go back to your slide. Let's talk a few things. You had that explanation slide where you think that the one pathway blocked, the other one not. Let's take a look at that. Go back to your slide that, yeah, Dr. Park was asking about. Okay, you have a longer tracing in this one? No, I don't want to know. I don't need to know your explanation. I need to see that slide that you show me. Tachycardia, it's only tracing, okay? Tracing of tachycardia that you reset, whatever. Yeah, that's the one. I don't know which one do you do.
Yeah,
This is the one. Okay. Let's take a look at this coronary sinus activation. Okay.
It seems like already fusion.
Yes.
Yes.
Caused by
Okay. Now, in my eye, I could be wrong. Your first two tachycardia rate. Okay. Two tachycardia in the right atrium, H1920, PP interval. Okay.
Yes, the same.
Yeah. And then you gave a PVC. Okay. Right. You gave a PVC from the septum, I assume.
Yes.
Because your AVF is biphasic, QRS complex. Right.
Yes.
So that favor to pre-exciting septal pathway. Therefore, septum blocked, right? Correct or no?
Yeah.
Yeah, because you're closer to the pacing site, pathway gonna block first if you have an equal refractory period. But that's what happened. I can understand that. So that ventricular premature beat afterward, what do you see? You said the tachycardia activation changed.
Yes.
And how many beat do you think it changed? Is the septal pathway complete blocked, truly blocked, or still conducting? The tachycardia rate between that first 2-bit pain on the H1920 and the last 1920. Go back. Is same or different?
The same.
Same. Then how do you explain that? If you have an X-ray pathway that was going through the septum dominantly, your tachycardia circuit is shorter than when tachycardia going to the left lateral pathway. Am I right?
Yes.
Then how can it be same? You need to explain that. Make sense?
Yes.
If you look at your His bundle catheter, your local DA timing, even after you reset, no, his 1, 2, go to 1, 2. There's a V and 8, small retrograde A, correct?
Yes.
Did they change after you reset? No,
No, it's the same.
that's the same. Then what you explained doesn't make any sense. Am I clear? You have to explain this. So what I'm trying to tell you, which tachycardia is the dominant here? You need to answer that to me first. Septal or the left lateral?
See, it's septal.
Septal. So that's why your tachycardia EKG look the same when you show me clinical tachycardia, first and second tachycardia you show me, because there was no change. So when you look at the tracings, you need to measure this interval carefully. There was one transient dissociation of septal tachycardia, which went to the left side, then came back around. Now, your duodeca catheter position, take a look at your duodeca catheter position. In X-ray, please show it to me. Your catheter placement, yes. So your duodeca catheter placement is fairly advanced CS into the left lateral, which is very good, okay? But if you look at the distance now from that RV catheter, you see that RV catheter where it is? In the septum, all right? His bundle straight up, yeah, and LAOB, you can see it. And from there, pacing, you can imagine how far your RV septal pacing have to travel to reset that left side pathway versus your septal his bundle recording X-ray pathway. Very sure, much different, right?
Yes.
That's a huge difference. So that's why you interpret the EGM always in relationship to your catheter placement before you jump in conclusion. Okay?
Okay.
All right. Go back to your tracing now. Let's go. Okay. I just want to point out that, which is the dominant. Why that matters. You gotta decide which one you're gonna play first.
I still have some question.
Yes.
After repacing, so the septal interval is separated. So in other words, it is blocked. But the always activation site might be
CS534.
3, 4, right?
Yes. Yeah. You got polarity 1 between 2, 1, 2, and 3, 4, 3, 4, 5, 6, right? The polarity reversed. Your retrograde P.
Right.
No, not there. Pointer H34, H56. Your initial complex of P wave is polarity negative positive. That means your pathway breaking through, right through there. Make sense?
Yeah, well, the sequence is a little different to the next, the continuous tachycardia, CS sequence.
Right. So just reset 1 bit.
Mhm.
That's why dominant pathway is the septal pathway. And unfortunately, we cannot see very well his bundle potential, which could be wonderful tracing to look at it. You don't have his bundle, so we can really argue which one did what, 100%. But just looking at the H activation, I think that's what we can infer.
Is there any possibility there is a third bypass tract?
Third bypass tract? Where? You just already described left lateral and anterior septum. Anything else you need to explain this? No. Right? You have no evidence. That's interesting though, if you look at your PVC complex, okay? Retrograde A did not advance. Look at the HRA, for example.
Mm.
It got longer PP interval. Okay, right?
Yes.
So you wonder, this is not just only accelerated pathway, maybe through the AV node or fusion going on.
It's also unusual.
That's correct.
Yeah.
And then subsequent bit accelerated a little bit faster because went through the pathway. Make sense? 그 subsequent PP interval 짧아졌잖아. 뒤에 거, 바로 뒤에 거. 맞지? 그러니까 you gave a premature bit, septal accelerated pathway blocked, then became a little more left side eccentric, but the retrograde P, instead of advancing through the, accelerated pathway, I think went through the also AV node together. This is a fusion bit. That's what I'm thinking. That's why only reason explanation why you can have a longer PP interval after ventricular premature bit. You should be advancing that P interval.
Right.
It didn't. It got longer. So you have a decremental pathway, or you got fusion between AV node and just the PVC to the left lateral pathway. That
That's what-
demonstrated,
That's
yeah.
what I want to say. Is there any possibility of decrement the left side bypass tract with decremental property?
Now, is it possible? You cannot rule out. As I said, if you had a his bundle, we could tell you that, but we don't have his bundle tracing. Okay. But fact is that you have, subsequent bit, PP interval got shorter, but yet you also have a two eccentric activation. In other words, septal pathway plus left lateral A also became early, suggests that that pathway cannot be decremental. 왜? PP가 짧아졌으면은 decremental property가 좀 더 길어져야지, BA conduction이. BA conduction the same. That's the argument is that I have for you. Okay? Okay, go ahead.
So after the conclusion,
Yeah.
this is the initial catheter position. We go first to the left lateral.
Okay.
And also this is our mapping catheter.
Mhm.
After placing catheter and the left lateral is bumped to the left lateral bypass tract, and we cannot induce the retrograde activation at the left lateral. So catheter position will change. We change the OB catheter and put it inside the AIV vein to
Okay. Is it
pass
ventricle?
the LV side.
Mhm.
And after LV passing, we can see a good retrograde at the left lateral bypass tract.
Mhm.
We start mapping. We found the signal from earlier 14 milliseconds to 25 milliseconds. We signal here. RF start from 1 to 9 at the left lateral bypass tract, but the first RF to 6 RF cannot terminate the bypass tract. But at number 7, before RS number 7, we found a very good accessory pathway potential, both anterograde and retrograde accessory pathway potential at the left lateral. So
Why you think that's actually pathway?
here and here, perhaps
Do you have any unipolar signal in there?
no.
And because it was a notching sharp potential, you think that's your actually pathway?
Yes.
That preceded your delta wave?
No, it's not preset the delta wave, but this is the conduction through the anterograde, not the through the anteroseptal, not the left lateral. That's why we cannot see the accessory pathway potential preset the delta wave, I think.
You're not making any sense to me now. If you have a non-manifested accessory pathway or dominant pathway through the septum, and you're mapping left lateral pathway potential, is that what you're saying?
Yeah.
So you must have evidence that that left lateral pathway is conducting, I'm assuming.
Yeah,
Right.
it's chosen between the anteroseptal and the left lateral conduction, but the anteroseptal is faster, then it's go down to the anterolateral first.
Yes.
Anteroseptal first.
Then how the left lateral pathway would be pre-excited. You see, your exotic pathway conductions are everything or nothing. What I'm saying, once you have a dominant exotic pathway, fusion is almost rarely seen. Because your interseptal pathway is located so close to sinus node compared to your left lateral pathway, there's no time for left lateral pathway to manifest. That's what I said. You need to look at the distance of a conduction to start thinking about this. So it is unusual to have a His-like potential in mitral valve annulus, guys. Yes or no?
No, it's not usual to
Not
have.
unusual. Not unusual. Many patients will have a His-like potential if you look at it carefully, and that can be okay. Now, retrograde conduction. If you do differential pacing, you preferentially conduct through the left side. Yes, I can believe you, but not in the antidromic pre-excitation. Absolutely not a chance. There's something else you're looking at it. Could it be axillary pathway? May not be. But looking at your trace, EGM, okay? The signal that you're looking is a far field, first place. That's a far field. Your near field is the QRS complex ablation that use P wave. You see that P wave, high frequency, sharp. What the point of P wave, your ablation, 1. Yeah, that's a near field signal. Next is a PB AP potential you're describing to me. That's far field. Look at the proximal, how broad that it is. The electrode 3, 4. Yeah, you see?
Yes.
It's a far field signal. So I'm not sure what you're looking at it. So anyway, so do retrograde pacing, then what happened?
This is retrograde pacing.
And then did you do B premature pacing as the same maneuver as you did during the tachycardia coupling or no? You
No.
You should have done that to prove yourself. Why? You want to see pure left eccentric activation through the left lateral pathway to reach the conclusion is that that's axillary pathway. Otherwise you cannot. Okay? That's what I'm trying to tell you. So pathway is specific for each electrophysiologic pattern of activation. So you need to block the interseptal pathway, only conduction to the left lateral pathway, record, then you're able to record a pathway potential and conform it. Again, in my eye, may be pointing just early retrograde A. That's possible. Okay. Anyway, we'll talk about that later. Let's go. Okay. Then what did you do? Ablate and successful?
Yeah, we start with power of 50 watt, 60 degree, 90 seconds, and after 7 seconds, the bypass track is gone. We can see the rest of the V and A interval.
Yes.
And A amplitude.
And then what happened? So left lateral pathway is successfully ablated. I can see that activation.
Left lateral is successful ablated, and we deliver to console ablation. And then we back to the subtor by mapping at the right subtor side. You can see the potential at the distal of ablation catheter at the anteroseptum, mid-septum, and posteroseptum. So at anteroseptum, there is a fusion between A and B. So we saw that there is the main bypass track is in the anteroseptum.
Okay.
So we change our ablation catheter to place it in the anteroseptum. And then
it's about trackers value is about 12 o'clock, right? In LA view, right? You're far away from his bundle. Correct?
Correct.
Okay. So this is a what type of interseptum? Suprahiscian?
Parahiscian.
Actually, this is an anterior axillary pathway of tragus annulus, right? His bundle looks like about 2 o'clock in my eye, or maybe 2:30. And your ablation is 12 o'clock, right?
Yes.
So definition between anteroseptum, okay? Anterior is what? You have to see far field his bundle potential on your ablation to be anteroseptum. When your catheter moving away from his bundle region, his bundle potential disappear. they already start becoming anterior pathway. And if you look at your 12-lead ECG after your left lateral pathway ablation, your B1 is what? Positive, R wave, initial 40 millisecond. Am I correct?
Yes,
Right?
positive.
That's after the your left lateral pathway ablation.
No, it's the first one. We don't have the ECG.
Yeah. You look at the left lateral pathway, successful left pathway ablation. Take a look at your ECG there, right? I saw R wave there. That's right. So bottom line, in B1 you have a R wave positive. Good news for you, is away from the his bundle. But if B1 is a QS, no, then you got a trouble. Okay, that's a message I want to give to you. The next time you look at the top 12 ECG, you suspect a pathway somewhere anterior anteroseptum, R wave has a B1, good for you. Gonna be tracheotomy free wall toward the free wall, so you don't have to worry about that his bundle. Okay, let's go. So you ablate that successfully?
Yes.
Okay. Now, if you go back to your ablation signal they showed to me, anteroseptum. Okay, yeah. Which signal is better? Hang here. Your ablation distal or proximal? Where would you ablate? Why that signal is no good? Your atrium is far field, right? Not near field. Look at the proximal ablation. Proximal ablation signal 3, 4. Right there. There's a beautiful potential there. A and what? Potential and small b. So if you're going to ablate anteroseptal anterior pathway, you want to have a bigger A than B. The reason is, first of all, you're more toward the atrial side of a tragus annulus. Second, your energy delivery is more efficient because tragus annulus is very difficult structure to target. And when you see such a small A, your ablation catheter is not stable. I bet they're shoving around back and forward. That's the reason I think you got rid of this pathway. And also typically anteroseptal pathways does not require too much energy. It's a very thin tissue. If I were ablating this, I would ablate the target 3, 4, not 1, 2. Okay?
Okay.
That's much I can tell you my experience. Okay, let's go.
So we deliver energy from 10 watt to 50 watt titrations. We get temperature from 50 to 55 degree for 90 seconds. The accessory pathway at the anterior side is gone.
Good.
Bypass ray is blocked. After that, we can see the signal.
Okay. Now, you did not tell me something about important the previous slide. Go back. No ablation that you had the block. Yeah, this one. What happened here? I see your his bundle, nice potential. Okay. Well, how do you interpret this second bit? You're pacing atrium. Am I assume? Am I right?
Yeah, passing atrium.
Did atrium capture?
Look like no.
What happened here? Is that echo bit? What do you see here? This bit here. Yes. Is another junctional bit?
Looks like echo.
Echo or junctional? You can tell. So what do you do? Subsecond. You pace faster. Make sure that you're not injuring AV node. Because you're letting anterior, even though far away, electric fluoroscopically. When you see even one single junctional like a bit, you can tell, sure, stop burning, pace, and burn again during the A pacing faster. Make sure you don't see any junctional suppression, watching the PR interval. Otherwise, you can have a heart block. That's the recommendation. Okay?
Okay.
That's what you're showing to me right now. So first bit, obviously capture, and then you got longer PR, and then you have unusual echo-like bit coming back up. This could be junctional rhythm, could be, as Dr. Hipak saying, dual AV nodal physiology echo bit. But I cannot tell you sure. So anytime in doubt, stop, and then pace the atrium faster, and then ablate. You got it?
Okay.
Good. Okay, very good. Let's go.
So this is the signal before the successful accessory pathway block at the anterior subtom.
Yes. It looks pretty good, actually, your ablation now. You see that? Big A, look at the A signal now.
It's A and
Yeah.
B.
Yes. And especially last two complexes are really good. Okay, go ahead.
So after successful ablations at the anterior side, we do the study, but still there is no decremental property at BA conductions.
Mhm,
460 to 320 millisecond.
mhm.
Still, there is no no decremental property. So we thought that there is another pathway possible. So we start, and also we found a subtle single echo at 270 milliseconds.
So where's the echo be coming through? Hank, go back. Where's the echo be coming through? CS? 7, 8?
Yeah, CS 7, 8. Yeah.
7, 8. Yes, 5, 6, 7, 8. You're correct. So you think this is another pathway? Or your left lateral pathway got messed up? What do you think?
We thought that there is another pathway possible at subtle side also.
Septal side. Your CS catheter 5, 6, 7, 8 is not a CS catheter? It's a septal? Really? Whether
No.
your CS catheter was that time? I thought that was your left lateral recording. Am I right?
Yeah.
So this is inside the CS you're recording, I assume.
Yes, inside the CS.
And especially 5, 6 has small negative potential, small one. Retrograde the A. BA, go to 5, 6. Drop. Yes, that small guy. Yeah, that's earliest. So your pathway actually closer to the 5, 6, not to the 7, 8. So then what did you do? Let's take a look. Go ahead.
So
Patient developed the right bundle also a little bit.
yes, after enteroseptal ablations, he developed a right bundle brain block.
Okay.
So after that, we try to met at the mid-subtoms area, and we burn at the mid-subtom area. So after deliver 1 RF energy.
So is that the mid septum or is it posterior septum? Wave of bleeding here. Looks like almost low pathway position.
Posterior septum.
Okay. So either right side, I assume, not left.
Yes, right side posterior septum.
It's almost like a roof of a CS to me. Okay. All right. Go ahead.
So after ablations, we found VA dissociations from
Okay.
the passing.
Mm-hmm.
And then after 15 minutes, it reoccurs again with the same activation pattern that earliest at 5, 6, and 7, 8. So
When
two
you burn,
more.
there was no junction rhythm. First beat, first time. So mid septum of posterior septal ablation, never junction rhythm during the burn.
There's no junctional rhythm.
All right. Good. Okay. Then.
And then after 15 minutes, it reoccur.
Okay.
We deliver 2 more RF. And then successful ablations, there is no VA conductions. So after that, we give adenosine 18 milligram, and also there is AV block, no AV conductions, anterograde and posterior and retrograde.
Okay.
And after ablations, sinus rhythm with right bundle brain block.
Right sinus with the right bundle branch block. Okay. Is the bundle branch block resolved next day? Hang or no?
The next day, still right bundle brain block.
So right bundle branch stays up there, did not recover.
Yeah, the next day still not recover.
Okay. When you follow up, you can tell us whether either right bundle branch block resolved or not.
Okay. So thank you so much. Still a little reviews about that. Clinical implications of the multiple bypass tract, higher incidence of VFib, high incidence of pre-excited tachycardia, complicated anatomy, because sometimes it's associated with congenital heart disease, and also tachycardia. Sometimes tachycardia change the Okay, sorry. So there is some evidence to show us that the patient have multiple bypass tract that we can find. First, changing in data well. This is taken from Josephson clinical electrophysiologist. Changing in data well on surface ECG, but it's very uncommon to see the change. And evidence of multiple road of retrograde atrial activation, like in our case, during V-passing, we found two types of retrograde atrial activations that indicate the patient have multiple bypass tract. And also there is a fusion between the two bypass tract during octodromic tachycardia, like in our case also, pre-excited tachycardia. And sometimes we also find that the patient have a A-type apical pattern of re-excitation on ECG, and the mismatch size of data well with the EP study, and also indicated that the patient have multiple bypass tract. That's all. Thank you so much for your attention.
And have you read any article about the atrial fibrillation interaction with the pathways?
No.
Okay. Just historically, I'll just let you know that old days we used to induce atrial fibrillation on WPW patient purposely to recognize multiple axillary pathway. Because of RR interval pre-excitation and wavefront of atrial fibrillation often can change the pre-excitation pattern if antegrader conducting multiple pathway presence in same patient. Okay, so something that you may consider if you suspect the patient has antidromic tachycardia and whether that patient has multiple tachycardia or not. Because as you said, people have a multiple tachycardia tended to have a more antidromic tachycardia via rest. So that would be some good, maneuvering. You can do that in the EP lab.
Okay, I will read
Right.
that.
Okay,
Thank you for your comment.
thank you for good presentation. Good job. Wonderful.
Any other question or comment?
Okay.
Okay,
The recording.
just in case. 선생님 자세하게 또 설명해 주셔서 감사드리고요.
감사합니다. 다시 많이 배웠습니다. I honored to participate in your conference. Okay.
감사합니다.
Thank you.
기록 중지하고.